Good morning, everybody. Good afternoon, and welcome to Dr. Gabone Qhsc Right Healthcare Solutions and Consulting. This is our first education and training virtual, preparing for Medical Mission 2022. We are coming in September 10 to September 27, but we'll be actively working from September 12 to September 23rd. We are all excited, and we have, as of now, the global volunteers. There are 21, so we are still counting, and we are graciously blessed with Dr. Msambi Chaka, so Dr. Lilian Msambi Chaka and Dr. Xavier Banera to give us the talk today. And I'm gonna let them give a little introduction, and then we're gonna start. So we do have some slides, and we will share the slides after the meeting. And there's a knowledge assessment. So we wanna find out who are the nurses, who are the doctors, and what did you learn from this training? Because when we come in September, we wanna make sure you guys remember and be able to demonstrate when we are in Tanzania. So I'm glad that people from Mwananyamala are here, people from Himbili, and people from Buguruni. So we are all squared away, the more the merrier. So if people miss this meeting, please, we're gonna have another one, I believe in 2 weeks, but we're gonna send the invite to make sure you, once it's set up the time. And if this is the best time, then we're gonna try to wake up early and meet you guys in Tanzania in the afternoon. So without delaying, I'm gonna welcome Dr. Lilian Msambi Chaka and then Dr. Xavier Banera to say a few things, and then I'm gonna let them start. Dr. Msambi Chaka?
Yes, well, thank you so much, Dr. Gabon. Thank you, everybody that has shown up. Habari zenu, Tanzania. My name is Dr. Lilian Msambi Chaka. I am a pediatrician and an internal medicine doctor, currently based in the United States. I practice mostly inpatient medicine, work with newborns, and I'm very excited to be one of the first people to host the first of this series of sessions with my colleague, Dr. Benella. So I'll let Dr. Benella go ahead and introduce himself.
Thank you, Dr. Msambi Chaka.
Hello.
Hey. Go ahead.
Okay. Hello, everyone. Dr. Gabon and Dr. Lilian, thank you for the opportunity to be the first speakers in the first session. As you can see, the class is still coming in the class. We have invited workers from the labor ward, operating theater, the obstetric theater, and the neonatal unit. So we expect them to come. As you said, maybe the first session is very important. If they miss this session, maybe we have to give them an opportunity next session so that we can be on board all together. Otherwise, thank you, everyone. Hoping to see you in September.
Thank you very much. We're excited. And thank you, at least, for making that effort to bring all these nurses and doctors from those units. Definitely having the theoretical background helps you to do your clinical skills. So we appreciate that. And those people who are going to probably miss, or either they have to work, this meeting is training is recorded, and then we're going to send the audio, sorry, the recording video and the PowerPoint afterwards. But also there will be a survey which asking you, once you see the video, then you have to answer those questions. That just validates what we, Dr. Msambi Chaka and Dr. Banera are going to share today. And if there's anything that we need to improve the next training, then we can cover that part. And people who are going to miss, they will probably be better to watch this video before going to the next meeting, so you can build on the knowledge versus just skipping part of it. So without further ado, Dr. Msambi Chaka, you're gonna take over. Let me share my screen and then we can start.
So just to really reiterate, today's topic is on newborn health and neonatal resuscitation. And it's one of the many series that we will be sharing with you until we get to the medical mission so that everybody feels prepared with the background information. Next slide, please. Again, my name is Dr. Lillian Sandachaka, and I will be sharing this topic with Dr. Benella. I have no financial disclosures. Next slide, please. So we're hoping at the end of this session that you will be able to understand the scope of the problem of newborn and maternal morbidity and mortality, understand the important role that we, all of us, healthcare providers play, understand the scope of the medical mission in the care of the newborn, review the physiology of the fetal cardiorespiratory system so that we can understand transition from fetal to neonatal life and how risk factors can complicate this transition. And at the end of this all, we're hoping that we can incorporate the knowledge that we learn above in the care of the newborn. Next slide, please. So just so that we're on the same page, I'm just, given that we're all healthcare providers, I can envision us having a day like this most of the time. A woman arrives in labor at 39 weeks gestation. The labor progresses rapidly, membranes are ruptured or clear fluid. Risk factors include fetal tachycardia and maternal fever. Mother has received intrapartum antibiotics for suspected choreo. The fetal tracing shows category 2 pattern. The baby is born with poor tone, does not cry. The OB provider holds the baby in a warm blanket, dries and stimulates the baby. Still, the baby has poor tone, irregular respirations. At that time, the umbilical cord is cut. The baby is brought to the radiant warmer. The airways open, secretions are cleared. The baby still has poor tone and irregular respirations. How many of you right now are sweating? Because this is what your day is like in the OB, in the labor and delivery ward. Well, thankfully, you do some positive pressure ventilation. The baby's tone and respiratory effort improve quickly. Their APGAR scores at 8 and 9 at 5 and 10 minutes. And we can all excel at this point. If you can relate, then you are.
So the goal of all of this is we want to make sure that we have healthy childhoods. And at the basis of all of this, healthy mothers plus healthy babies are a good start to a healthy childhood. And the question that we have to ask ourselves is, how do we get there? Can I go to the next slide, please?
Yes.
So just for some background information, I think this is probably not news to all of us that take care of mothers and babies, that there is a high mortality for newborns and mothers during childbirth. And the statistics are very grim, actually. If you look at some of the most recent data, especially for countries like sub-Saharan Africa, you will notice that every year we have about 2.6 million babies that die in the first 28 days of life, and most of them in the first weeks. And we have an additional 2.6 million stillbirths that occur each year, with 50% of them that are actually happening right during, 50% after labor has already begun. The top causes of all of this, number one is prematurity. Number two is complications during birth. And then number three is severe infections. But, the good news is 75% of newborn births can be prevented with high quality care. So can the majority of maternal deaths and stillbirths. So there's a lot of good and impact that we can have if we just do a better job taking care of these patients. Can I go to the next slide, please?
Yes.
And so this is the good news. And one of the things that I found very impressive, which is probably not news to my colleagues in Tanzania, is that Tanzania is actually part of the global Every Newborn Action Plan, which was launched in 2014. And this is a roadmap of strategic actions for ending preventable newborn mortality and stillbirths, reducing maternal mortality and morbidity. And the reason we joined this consortium is because as a country, Tanzania has one of the highest newborn mortality rates. It's, it's good to be in the top 10 most of the time, but it's never a good thing to be in the top 10 of the countries in the world that has some of the highest rates of newborn mortality rates. The good news is, as a country, the government and the healthcare system, we are working towards improving some of these outcomes so that we can make them better for our families and our friends. If we could go to the next slide, please. This part here is just to highlight. So that was all just background information leading us to this roadmap, which is the mission. And the goal of this mission is that by the time we get to September and we actually come and work along you all, it's that we want to have some basic steps. We know that the time is limited. We know that we want to spend a lot of time at the bedside, but to get there, we would like at least to start building some of the building blocks so that when we get there, it's all hands-on. And this is our roadmap that we should expect for the upcoming few months up until September. Right now, at the very beginning, we're just reviewing the basics of neonatal transition. Most of you already know this, so this is mostly a refresher, just so that we're all on the same page. And then subsequently, we hope to start honing in on newborn resuscitation with a focus on ventilation. And then after that, we will look at the helping babies breathe pathway. And then finally, we're hoping to incorporate some of the neonatal resuscitation program material, which is what we use in the United States, but that cannot be effectively used yet in Tanzania, just given that just the equipment that is needed. But we're hoping, in the future, maybe a few years from now, that can become standard of care. And ultimately, we will have our hands-on training. Next slide, please. So moving on to the newborn physiology. As we know, most newborns make the transition to extrauterine life without any intervention. It's a miracle that actually that happens. Within 30 seconds after birth, approximately 85% of term newborns will begin breathing spontaneously. An additional 10% will begin breathing in response to drying and stimulation. 5% of them will require some positive pressure ventilation. 2% will be intubated. So as you can see, the bulk of the change that we can make to reduce the infant mortality is right there. We have a few, like the 2% that might need intubation. So if we don't have intubation where we are, that might be a challenge. But there's a lot that we can do for the majority of the newborns. Next slide, please. So why should we care? Like I said, even though the majority of newborns do not require intervention, the need for assistance cannot always be predicted. Healthcare providers need to be prepared to respond quickly and efficiently at every birth. And timely intervention can save many newborn lives. As we know, the mother can have a healthy pregnancy, no risk factors at all, but the transition itself can be challenging for multiple reasons to the baby. And so really, we just need to know how to respond to these challenges and be prepared at every turn. Next slide, please. So the goal of all of this is what we're trying to say is we want to help you learn the cognitive, which is what we're working on in this education series, the technical aspect, which is what we're hoping will cover some of it virtually and most of it when we actually do hands-on. And the teamwork skills needed to resuscitate and stabilize the newborns. Next slide, please. So I want to take us back to the case again and just think about all the factors that are involved in the care of mother and baby. And the question to ask ourselves is, what happened here? Why did this baby struggle to transition? Can we go to the next slide? So I would say that in order for us to answer this question is we have to review the transition of the fetal and neonatal circulatory and respiratory systems. We have to understand thermoregulation in the newborn. We have to understand glucose homeostasis. The fetal transition with the cardiorespiratory system is what we will focus on with Dr. Benella in this talk. And then after, in the subsequent talk, Dr. Tony and Dr. Ngido will talk about thermoregulation in the neonate and glucose homeostasis. So we will not cover that part today. Next slide, please. During fetal life, the placenta, as we all know, carries out the crucial physiologic roles of gas exchange, nutrition, elimination of waste products, and additional aspects of circulation. And just like that, within minutes of birth, the placenta support ceases. So the baby's own cardiovascular, respiratory, gastrointestinal, renal, and metabolic system must function independently. I'm always in awe that this actually happens smoothly the majority of the time. Can we go to the next slide, please? So in summary, the majority of infant deaths occur within the neonatal. The majority of the infant deaths occur within the neonatal period. That is the first 28 days. And these are linked to inadequate progression to neonatal physiologic function. Again, I think this is very low-hanging fruit that we can make a huge impact on as long as we get the skills and the knowledge that we need to take care of these children. Next, please. And I'll let Dr. Benella talk about prenatal physiology of the newborn so that we have the background that we need to understand what is happening at transition. Dr. Benella, I yield to you.
Thank you. Thank you, Dr. Lillian. Dr. Gabon, can you hear me?
Yes, I can hear you.
Okay, so I can Carol?
Yes.
Yes. Can you please go back to a roadmap slide? Roadmap slide. Yes, I want just to trace back the importance of our roadmap, that at the end of the day, we will have a space training live here at Mananyamala and the other places in Nigeria and Burundi. So I want to insist to my colleague here to follow the sessions before we come to September, where we'll have a live skills training here at Mananyamala. Thank you. Next slide, the first slide. So my talk is the physiology of cardiorespiratory system of a fetus while in the uterus. As we all know, the condition is not the same as we adults. So there are mechanisms which have been put in place for the fetus to survive intrauterine. These are structural, physiological, and function. Next, please. And here I'm tracing the difference between the adult secretion and the fetal secretion. As it has been said, placenta here is the main source of oxygen. It's where the oxygenation is taking place and not in the lungs. So is in adults, there are no shunts which are just closed just after birth. So we have three main shunts which the fetus are there to survive. Next, please.
Recording in progress.
These two structures, they're just showing the difference in the circulatory system between the adult and the fetus in uterine. We have three main shunts that are put in place so that the oxygenated blood does not go to where it's not needed. The first one is ductus venosus, and that shunt prevents the oxygenated blood from the placenta to go throughout the liver. And the second one is the foramen ovale, that shunts blood from the right atrium to the left atrium, preventing the blood from going to the lungs. And the third one is ductus arteriosus, and this one also prevents blood from the left ventricle or right ventricle going to the lungs, where it has nothing to do with oxygenation. So these shunts are the main difference between the adults and the fetus in the uterus. Next, please. Okay, those are the shunts which I've just talked about. Next. So the importance of the shunts, as I've said, you see the blood from the placenta is oxygenated. And we know that the oxygenation is not 100%. So to keep that oxygenation of blood to go and supply vital organs like the brain, the heart, there are shunts which prevent the blood from going elsewhere where they are not important. It's not that the liver is not supplied. It's supplied with a fewer blood. The other thing from the shunts, we can see a blood coming from the lower part of the body of the fetus. It's going through the same vessel where the blood is being shunted. That's the blood is being shunted in the inferior vena cava. The same blood is taking the oxygenated blood from the lower part. But within the same vessel, there are streams. One side is more oxygenated than the other one. So it's very important to understand. And the other thing is in the adults, we have the cardiac output being determined by left ventricular stroke. But here you have a combined effect of both the left and the right ventricle. When they push together, you have the big outcome. That's where we say the outcome is the combined effect of the two ventricle functioning well. The other thing I think we are aware, the fetal hemoglobin has more affinity of oxygen compared to the adult. We know the curve is more shifted to the left than the other. That it can capture the oxygen wherever possible. Next, please. Oh, that picture just try to illustrate the difference percentage of oxygen as it comes from the placenta to the vital organs like heart and the liver, and all the way back to the placenta. So the importance here is for us to understand the importance of the placenta as a place where exchange of gas and the other waste material takes place. Next, please. Okay, here we are talking about the fetal heart monitoring. We know for us here, we monitor our babies in the pregnant woman using fetal heart rate. And here we are looking at the determinants of a good heart fetal heart rate, and when we have a fetal distress, what is happening inside. And the most important thing we want to understand is the blood supply to the uterus. Blood supply to the uterus is the most important thing here I want to stress. We all know the normal fetal heart rate, and it's vary according to gestation age. But when you have something wrong in the blood supply in the uterus, you have the clinical effect in the monitoring of our fetal heart rate. Next, please. So we say in clinical practice, it is reasonable to assume that a modest variation in the fetal heart rate within a normal range is an effect of a small change in cardiac output or cardiac, or I can say the supply to the uterus. But if you have a big change in the fetal heart rate, then you have a big compromise in the supply of blood supply to the uterus. Like we can see later on the effect of maybe abruption or any effect to supply the uterus. Next, please. Okay, we wish to trace the importance of blood supply in terms of the exchange which is taking place in the placenta. It's not the perfusion or diffusion rate in the placenta and the uterus, but rather the blood supply to the uterus, and therefore the blood which is going to the fetus through the placenta. So, and here we will let us see the effect of chronic hypertension or severe preeclampsia or pregnancy-induced hypertension, which have effect in the supply of the uterus. And for that matter, even the gas exchange will be affected. Next, please. Okay, we have this fact that if you have a 50% change of blood supply to the uterus without a big effect to the fetus. You see, you have a 50% change in blood supply to the uterus without a big effect to the fetus. But this applies to the normal growing fetus. But if you had a fetus who had been compromised either by chronic disease or growth restriction, that effect will have a different outcome. Next, please. Okay, that's my point here is we have a room to correct any physiological change to the woman before we lose a baby. Next, please. These are some of the factors which determine the transfer of either gas or waste product between the placenta and the uterus. We see the importance of the blood supply to the uterus. Or at the end of the day, we have other factors, as I said, the affinity of fetal hemoglobin. But more important, I think, is the fact that the hemoglobin of a fetus is higher than the adult, so it can extract the little oxygen available compared to our adult hemoglobin. Next, please. Okay, we understand the blood supply to the uterus during pregnancy is very significant, and it has been made there to allow for gaseous exchange and waste product. So if you have 10% of the cardiac output going to the uterus, that is one of the physiological changes made to secure the fetus. Next, please. So some of the factors we all understand that the effect, the importance of blood supply, and then when you have any factor which compromises the supply to the uterus, will affect the cardiac output, and for that matter, will affect the fetal heart rate. These are the common ones. We all understand if you have uterine contraction, especially tetany, which are not controlled, and this can be caused by either overstimulation or any medication. We know Qhsc, we know misoprostol. After its initiation will affect the contraction. Sometimes without any medication, somebody will have, we say, precipitate labor. So you have the effect directly to the uterus, to the blood supply, and at the end of the day, you have the effect to the fetus. We understand postpartum hemorrhage. That's why we have a room. I say you have a 50% decrease in cardiac output without a bigger effect, without moving a bit. So sometimes we have a blood placenta with a live fetus, but you have a limited time to save that thing. We know the hypotension, superhypotension, preeclampsia, hypertension, or chronic hypertension. These all they have effect to the blood supply to the uterus, and for that matter, the effect to the baby. So you have chronic hypertension for a long time. You will have a chronic effect to the fetus. That's why we get growth restriction. And when you have any effect, compounding that effect, the chance to save the baby is more difficult. Okay, next. I think this is my last slide. My last slide here, I asked myself about bed rest in pregnancy. Here I was trying to stress the importance of allowing more blood going to the uterus. That's why some women, if they have maybe chronic hypertension or PIH, we advise them to have bed rest. The most important thing there is for her to have enough blood supply to the uterus, so that the baby continues to have its nutrition, including the waste metabolism. The other question I asked myself, the fetal distress. This training maybe will give us how to resuscitate a baby who has gone the 5% or 10%. We understand the Dr. Sancheka said most of the babies will need no resuscitation, but very few will need resuscitation. So actually the physiology starts during pregnancy or intrapartum. So that room which we are given to save mostly is time bound. It's time bound. That's the most important I want you to stress. After that words, I would like to thank you, Dr. Gabon. I think Dr. Lilian may take us to the end of our presentation.
Before I let Dr. Lilian Msambichaka continues, if you have any question to our facilitators, please, you can put the question on the chat, and then after Dr. Lilian Msambichaka finish up, then we can they can start answering those questions. But if you can, just put them on the question, then it will be easier to ask them, then they can target it as soon as they can before the Q&A session. Dr. Lilian Msambichaka, I'm going to let you continue.
Yeah, thank you so much. I hope, okay. So thank you, Dr. Benella, for that very important transition from, intrauterine to extrauterine life. And that's why it's very important that the obstetrician, the midwife, the nurse, the pediatrician all work together, because what one does impacts what the other is going to do. I'm not going to belabor this, but this is just the side by side of what Dr. Benella was talking about. You can see what I've highlighted there. Before the baby's born, you have all those shunts, and then you have the ductus venosus, the open foraminal valley, the ductus arteriosus, and then right after birth, those transitions start happening, and then you see that they're closing. Can I go to the next slide, please?
Yes.
So again, just in summary, before birth, I wish I could point, Harry, can you point to the fluid-filled lung, please? The top right,
Okay.
right
That's
there.
what I was-
Yeah, yeah. So if you notice that before birth, the lungs have, just physiologically, the lungs have constricted pulmonary vessels, therefore they have increased resistance. Oxygenated blood bypasses the lungs. It goes through the foraminal valley or the ductus. And this is what Dr. Benella was talking about, the right to left shunting. And this right to left shunt is what allows most highly oxygenated blood to flow directly to the fetal brain and the heart. So the lungs are not really doing a whole lot right now. Next slide, please. And then a miracle happens. The baby is born. They take that deep first breath, and all of a sudden, the constricted pulmonary vessels that we were talking about, they relax. Blood now flows to the air-filled lungs. As you can see that, there's air now. And then you have blood return to the left side of the heart from the lungs, and then the lungs take over gas exchange. And this is very key for us to understand this transition right here, because it means life or death for the baby. Can we go to the next slide, please? I think I have a delay on my end. Are we on the next slide?
Yes, please.
Okay, I have a delay on my end. So the next slide should be talking about, it's just another schematic that's showing the transition. Again, if you look, follow me from left to right. So before birth, the lungs are filled with fluid. Baby is born, takes deep breath, and then you can see the next little alveoli there. Deep breath, the fluid is being squeezed out of the lungs, and air goes in, and the more breathing we have, the more the fluid comes out, and then voila, the lungs are completely filled with air at this point. So respiratory failure can occur if the baby does not initiate or cannot maintain effective breathing effort. So if respiratory failure occurs either before, as we talked about some of the compromises that Dr. Benella talked about during pregnancy, or after birth, the primary problem is a lack of gas exchange. There's just no gas going through in and out of the lung, and that impacts transition. And therefore, in pediatrics, the primary focus of neonatal resuscitation is effective ventilation of the baby's lungs. The baby needs to breathe. Most newborn hearts are normal, they're healthy. Unlike the adult hearts, which is when an adult collapses, it's usually the problem with the heart. With the newborn, it's usually the lungs. And so if we ventilate, we can help with that transition. Next slide, please. So the next, we're just going to now incorporate some of the things that we need to be aware of as we're transitioning to neonatal life. How to anticipate and prepare for delivery, and how to help with effective transition. Next slide, please. there's what we call, and from going just out for context, from now going forward, most of the material that I'm sharing with you is based out of the most current newborn resuscitation program as is taught here in the United States, but it also incorporates some of the things that you're already doing and some of the things that are already part of helping baby breathe. This is pretty much typical newborn care standard of care that we should all be following to assist with the transition. Like I said, the most important thing is having a conversation with our obstetric colleagues and asking the question. So the first questions that you have to ask yourself before you go to any delivery is, what is the expected gestational age for this child? Is the amniotic fluid clear? Are there any additional risk factors? What is the umbilical cord management plan? And the reason you ask these questions is, as we talked about physiology, you know, if the baby is 28 weeks, it's going to be a different transition than if the baby is 39 weeks. You know, if the amniotic fluid is clear, or if the amniotic fluid is, can you guys still hear me?
Yes, we can.
Okay. If the amniotic fluid is clear, whether there's meconium or whether, you know, there was abruption and there's blood, if there's any additional risk factors. And so if I use our case that I illustrated at the very beginning, is you have a term baby with a clear, you know, question one, what's the gestational age? Well, the baby is term, it's 39 weeks. What's the amniotic fluid? Is, you know, the answer is it's clear. And you ask, are there additional risk factors? And in this case, we're told that there's fetal tachycardia and there's maternal fever. And our obstetric colleagues are concerned that there's chorioamnionitis. And already you can see that the fetal tracing is showing some sort of fetal distress. So as you walk into the delivery room, these are some of the things that you should consider. Next slide, please. I think I'm getting a delay in
Yeah.
So this slide, again, talking about risk factors, the point of all of this is just to let everybody know it's like risk factors can complicate or delay transition. And therefore we should always be prepared for every delivery, but you should even be extra prepared if the baby that you're going to attend the delivery for has any extra risk factors. There's obviously the antepartum risk factors, and then there's the intrapartum risk factors. And in our case, the two risk factors that this child had is there was choreo and there was a non-reassuring fetal heart tone. Next slide, please. So what I was trying to emphasize here is, again, every time you're walking into a delivery, you should make sure you assess the perinatal risk factors. You should ask the 4 pre-birth questions. You know, what's the gestational age? Is the amniotic fluid clear? Are there any additional risk factors? And what is the umbilical cord plan? And based on this, you should assemble the team based on the risk factors. You know, if it's going to be a preterm baby, that you might need extra resuscitation. So you should probably not be the only person in the room. You should probably ask for help and just perform your equipment check. Make sure you have everything that you need to deliver this baby. We should always be prepared to resuscitate newborns. I can't stress that enough. Again, illustrating back to our case, every time, once you have the baby delivered, the first things that you should ask are, does the baby appear to be term? Does the baby have good muscle tone? Is the baby breathing or crying? These are very key questions because it will impact what you do next for the child. If the baby is term, has good muscle tone, they're breathing or crying, everybody's happy. You can just, have the baby be with mom and transition. In our case, is the baby term? Yes. Does the baby have good tone? No. Is the baby breathing or crying? No. And so that by itself makes you have to initiate the steps of newborn care. So providing warmth, you dry and stimulate. As we can see here, this is what happened. The baby did not cry, had poor tone. The obstetrician provided warm blankets, dried and stimulated the baby. You ask again the same question. Does the baby have good tone? Are they breathing? The answer is no. You cut the cord, bring the baby to the warmer. Again, you open the airway, you clear secretions. You ask the question again, is the baby crying? Do they have good tone? The answer is no. You ventilate. And that, as we talked about, helps with the transition. Fluid coming out of the lungs, air going in, and the transition happens. I would like to just share a brief video. This is from the Neonatal Resuscitation Program that kind of illustrates what I just talked about.
The baby is born and a rapid evaluation is performed. This baby is term, but has poor tone and does not breathe or cry at birth. The baby arrives at the warmer limp and apneic. Her mouth and nose are suctioned in anticipation of positive pressure ventilation. She's dried, the wet linen is removed, and her head is positioned to open her airway. Despite these initial steps, she remains apneic. PPV begins immediately within the first 60 seconds after birth.
Thank you, Dr. Gabon. I just wanted to illustrate, the evaluation of a newborn should be something that's very systematic. It should always happen the same way, in the same order, whether you wake up from sleep or you've been awake the whole time. And that is how we become effective at making sure that newborns transition well, especially the ones that are at risk. And you should be aware of some of the abnormal findings during transition: irregular breathing, apnea, tachycardia, tachypnea, bradycardia. Those are not normal. Those are signs of distress. If you see decreased tone, if you see, if the color, if the baby is pale, or if they're cyanotic, if you're checking their oxygen level, they have low oxygen saturation, if they have low blood pressure, those are all clinical signs of abnormal transition and should prompt you to do further evaluation and ventilation. So I go back again to the same case that we had in the beginning, and just to, why did I keep bringing up this case? What I wanted to just show for this particular case is how we can incorporate all the knowledge that we learned about how a newborn is the placenta does all the oxygenation, and then the first breath is the most important, where now the newborn takes over the breathing, and how transitioning that, helping the baby continue to take over their respiratory function by themselves, can be impacted by so many factors in between. And we have the ability to help with that transition depending on how we respond, especially, preterm and after, during labor and right after labor. So just to summarize what we've been discussing here, before birth, fetal breathing function is performed by the placenta. When the placenta respiration fails, usually there's insufficient oxygen supply to the fetus, which can result in acidosis. And fetal monitoring may show when there's acidosis, decreased activity, loss of heart rate variability. You can have decelerations, apnea, and bradycardia. And it's very important for anybody that's attending a delivery, if you're obstetrician or midwife, to communicate that to your pediatric colleagues that you are seeing signs of fetal distress, because that helps the person that will take care of the baby once they're born to anticipate that there might be a difficult transition. I have this color-coded as green, yellow, and red, just to highlight that, hey, if the fetus is born in the early phase of respiratory failure, usually just tactile stimulation may be sufficient, and the transition will occur pretty smoothly. However, if the fetus is born in a later phase of respiratory failure, just be aware that stimulation alone will not be sufficient, and the newborn might require some assisted ventilation. And lastly, this is what we usually don't like to see, in which case the most severe affected newborns that might actually require chest compressions and medications. And that's what we're trying to avoid as much as possible. Next slide, please. So after birth, the baby's lungs take over the respiratory function, and respiratory failure can occur if the baby does not initiate or cannot maintain effective breathing effort. So in a newborn, respiratory failure before or after birth, usually the primary problem is lack of gas exchange. If I can just remind everybody that primary problem, lack of gas, and therefore ventilation of the newborn's lungs is the most important and effective step in neonatal resuscitation. Obviously, we will work on the actual technical aspect of it, the skill, perfecting that. But in order for you to use the skills, you have to understand why you're doing what you're doing. And this is the why. And with that, I will thank you for your time. We will take some questions if anybody has any questions at this point.
Thank you, Dr. Msambichaka and Dr. Benera, for excellent presentation, and give us a little review. And I'm sure a lot of people have a lot of questions. Before I do that, I just want to acknowledge Dr. Kilowoko, in charge of Buguruni Health Center. If you are up there, thank you very much for coming. And if you want to say hi, and then we'll go back to the questions, because we're going to need your help to help us with people in Buguruni, so they can join with us and learn as much as they can. Dr. Kilowoko, are you there?
It did not show on a microphone.
Oh, okay. So that's fine. We probably give her the chance towards the end after the questions. Okay, the floor is open, guys. Oh, they still don't have the. That's okay. Anyone has a question for Dr. Benera or Dr. Msambichaka, please? If you have any question, just unmute your mic and then ask the question. Anybody? Or raise your hand. Oh, Mwananyama, did you raise your hand or you're waving back to me? I have a question. I have a question. So as a labor and delivery nurse, I am going to attend the delivery. So my assumption is whoever the labor and delivery nurse is, I should be aware of my patient. That means I have to screen the mom to make sure I identify those risk factors that Dr. Msambichaka identifies. And then I remember the physiology, what Dr. Benera said. And then so I'm new, and I've never delivered the baby by myself. So if I need help, how many people should be there at the delivery, and who should be doing what? Dr.
Is that a question for me? Oh, okay. That's so that's an excellent question, because like I said, risk factors helps the person that will be taking care of the baby determine how many people would be at a delivery. So if it's a mom that's coming in that has had good prenatal care, no risk factors whatsoever, usually just an experienced provider who is experienced in providing neonatal resuscitation can attend the delivery. So it could be you, the labor and delivery nurse, or the baby nurse, so a dedicated person. So it should be a dedicated person for the mother and a dedicated person for the baby. I understand sometimes that's not always the case, but whoever is there should be experienced and comfortable taking care of the newborn. However, if you tell me that you have a mother, again, received good prenatal care, but now intrapartum, they're having trouble, they're hypotensive, they are febrile, there's concern for infection, then definitely you want somebody there, like a pediatrician or another experienced person, just for the baby, because you can already anticipate that this baby might struggle with transition. It might not be the case, but you don't have time. Like once that baby is born, you have seconds to do the evaluation. And then if you're talking now, like move the spectrum, it's a preterm, it's a premature baby, and you know, mom maybe like just be a virtue of being premature, or if it's like twin gestations, then you need more people there. Because as we talk about, we didn't go into this because we assume everybody has had some sort of physiology class. If you're 28 weeks or 32 weeks, your lung maturity is definitely very different than a 39-week or 40-week baby, or even a 37-week baby. So you would anticipate that you would need somebody to wrap the baby to provide warmth. You will need somebody to maybe intubate this child, or you just take over the airway. So you will need more hands than just one person. You might need two or three people even at that delivery. So screening of risk factors as a brand new nurse is very important, and knowing what your limitations are, because if the mom is high risk, the baby is also high risk. So you need to reach out, either have another colleague there, call for an person that's comfortable and trained in taking care of the baby. That is how you save that baby's life.
Thank you very much, Dr. Msambichaka. Dr. Bernard, do you have anything to add to it before we let the next question?
Not really, but I would say anticipating the outcome of the baby is very important, so that you get prepared, and even you are alone, you can call the team before the baby coming out. Thank you.
Thank you very much. Next question. Anybody?
Yeah.
Good afternoon.
Good afternoon.
My question is from the first presenters. First presenter said the neonatal mortality in Tanzania is, in worldwide is 2.6%, and majority coming from the developing countries, in which Tanzania is included. So most of the time, these mothers came very late to the hospital. We find sometimes the mother came in the second stage of labor, of which to anticipate the fetal phase, coming to the emergency salon section, the outcome is very poor. At the end of the day, we end up with this bed at 6 years. So I think maybe from the program itself, we did have the intervention from the family levels, because not only healthcare providers, and from the family levels, how can we intervene to prevent these mothers coming very late with fetal distress and the poor outcome of the neonatal?
Yes, that is a very excellent question, and I think that is probably like the second. Like there's two parts to this. There's good prenatal care, health literacy, and then there's postnatal care, which is what we are providing depending on what we get. So we usually have no control over, like you said, mom coming in like second stage of labor and fetal distress, and all we can do is provide as much support as we can after the baby is born. But I think the first part that you talked about is going to take us a system change, a policy change, and just a campaign for education awareness. Because without mothers, like if they go to like the antenatal clinic, for example, for their routine care, how much education are they getting in terms of like what to prepare for, when to come in for, you know, for when, what are some of the signs that they should now come in for evaluation of, you know, potential labor. And that's not something that I think we can fix right now, but definitely something that makes it very challenging for us healthcare providers as we're trying to improve outcomes for these babies. Because like, yeah, there are times that even with the best efforts, we are not able to save the baby because there's just so much distress and damage that has already happened before the baby is even born. Maybe Dr. Benella, you can talk about like how, like what kind of education is being given to mothers during their antenatal clinics as they're preparing to, you know, to come for labor and deliver.
Yeah, thank you. I think that the question from our pediatrician here is very valid for us. In terms of systems, I think we have a very good system here in our country. Even the SOP or what to do when the woman is attending the clinic is there. Probably we need to insist on that opportunity when you have the woman in the clinic. We mostly miss some of the opportunities of health education. The content, I think is there, but maybe the importance of I would say a structured and probably every session we have this called focused adult care, which insists the importance of treating every woman individually. So you can, and we are insisted to look at it socially, economically, and even education-wise. So if we take that as a homework, I think we have a big role to do that rather than the other side where you have a woman coming late, but she had a chance to come to a clinic or to a facility, maybe 4 times. So that opportunity, I think that's where we are missing some of them. Otherwise, the other side of community education is not going to work well. Otherwise, the opportunity when they are coming, I think we need to make more effort on health education. Probably individualized education is more important. Otherwise, we are still going to get these women who are coming late in second stage, and then you can do nothing. Or if at all you can succeed, you end up with a business fixable.
Yeah.
Thank you, Dr. Benella. Thank you, Dr. Msabichak. I would like to add something, and I'm sorry I didn't get the name of the person who asked that, an excellent question. What's your name?
Dr. Akida.
Dr. Akida.
Dr. Akida.
Yeah, so thank you very much, Dr. Akida. I'm going to add to it is that, yes, we in a perfect world, we want the patients to know, the pregnant patient to know everything they need to know about their pregnancy and follow and come to the hospital when everything is mapped out. However, we are living in a world that people have choices. So when they show up late, second stage of labor, means the baby is coming out whether you like it or not. Dr. Msabichaka said all those 4 questions that you asked yourself, and that's the reason of this training. We have to be prepared for the unknown, because we can know all this knowledge as much as we want, but when the patient shows up, they don't follow the script, they show up with their conditions, and then as healthcare workers, we have to arm ourselves with education, attending this training, practice as much as we can, do those mock drill, what you call mock drill, like you learn, you do clinical practice, and then you simulate the actual event that could happen, well, even if it's not happening. So being prepared, so then you can take care as much as you can, because you can ask the right question at the minimum time that is required, and then you can prepare and take care of that patient. Because most of the time, 98% of the patients who come in, we have no idea what is going to happen. We can assume by screening them, but more likely you don't know what is going to happen. And we have to be prepared as healthcare workers. So that was an excellent question. I'm glad you asked that. Any other question?
I have a question.
Yes.
So in Tanzania, especially in Tanzania where we're going, what would you say is the most high risk factor? Is it because they don't have equipment for like thermoregulation, or if the baby has respiratory problems, do they not have the high pressure airflow, the education?
Do you want to introduce yourself first before Dr. Msambichaka or Dr. Benera answer that question?
I'm Bree.
Who is Bree?
I'm Dr. Gabon's student.
She's a nursing student who is going to be coming to the medical mission. So thank you for your question. We can start with Dr. Benera, answer that question, and then Dr. Msambichaka can add to it.
Dr. Gabon, can you repeat the question for me?
Bree, can you repeat the question? I think she's asking, I mean, what are the potential risks that the patient might be having? Is the outcome being bad? Is it resulted in the resource, or is it resulting in the knowledge, or is it resulting in like a screening process? You know, like what do we need to prepare for this patient? Do we know what the patient comes with? What is the common things happen in Tanzania?
For me, the most common thing is knowledge and skills. Yeah. The woman can come late, but if you have something to do, you can make the difference. But that one, I think we still lag behind.
Dr. Bennett, Msambichaka?
Yeah, if I can chime in, Brie, like we said, like, you know, the majority, like up to like 90% of newborns will transition just by themselves or with very little assistance. And so lacking, you know, equipment like intubation equipment, you're talking about probably 5 to 10%, actually less than 5% of the babies that might actually need that. As of right now, just based on our conversations, we know that Tanzania, they do have ability to deliver positive pressure ventilation. I think I would venture to say that the knowledge and skill is probably one of the things that might be the limiting step. Like Dr. Benella said, if you have a newborn in distress or you don't recognize, you know, that's the other thing, you don't recognize that irregular respirations are not normal or grunting is not normal. That baby might have transitioned, you know, the first 5-10 minutes just fine. And then they start grunting at minute 10 and you don't recognize that as being distress and don't do anything about it. You could lose that baby. You know, not recognizing simple things as thermal regulation, which, you know, just having the delivery room be a certain temperature, making sure mom and baby are doing skin to skin to help that baby regulate their temperature, you could lose that baby. You know, recognizing, you know, screening to make sure that, hey, this mom actually had diabetes in pregnancy and now the baby is born. I should be concerned that this baby might have hypoglycemia. You could lose that baby. So there's certain, like, without that knowledge, there's so many things that you could miss intervening on the baby. And most of them are very like low hanging fruit. You don't need a whole lot of like resources to do that, except for the few that are high risk. But the majority of the babies that we're probably losing are babies that could be saved with like very low technology and no technology, like just using what Mother Nature gave us for some of them.
Thank you, Dr.
Thank you.
Msambichaka. Any other questions?
Hello, my name is Maricela.
Hi.
I'm also a nursing student at South University. I have kind of a twofold question. It was a little bit about pertaining to what Dr. Msambichaka said. As a mother, on the mother's part, as she comes in, what all screenings are being done, or kind of like questions are being asked to her to kind of help identify what risk factors could she potentially have, and then on the infant side, I guess you can say, when it comes to the infants, like, are we, well, not you, but are the mothers being explained like the different things to look out for at home, while they're at home, so, like whether there should be monitoring how many times the baby's kicking? Right, it's my dog. Are they being told like how many times they should monitor how many times the baby's kicking and stuff like that to kind of help give them some type of knowledge on to when to actually contact their doctor for help?
I can answer probably the first part of your question, and then I cannot speak to how it's being done in Tanzania for the second part of the question regarding what the mothers are being taught, but I can, like Dr. Benella or somebody at Mwananyamala can probably help us with that. I can speak to what we do here in the United States and see if any of that translates. So in the United States, every time you go for your prenatal visits, you're given information depending on this, you know, how you're progressing during pregnancy. They do screenings, which are standards, you know, screenings like this.
I'm going to add just a couple of things while she's coming back. Yeah, so for United States, the pregnant women, we get a number of tests during screening. So we're hoping that also the patient will go to the OBGYN to get prenatal care. And during the prenatal care, I mean, they will have all the lab work, all the STIs, whatever they need to know about that patient. And according to gestational age, they will give them a specific instruction. When you are 25 weeks, these are the risk factors you should be looking for. These are the clinical findings if you have for your doctor. When you're 37 weeks, these are the things that you need to know at home, how many times the baby should be kicking in your uterus. And if not, then this is what the way you do. Drink something cold to try and count the baby's fetal movement. And then if not, then call for the doctors, the hospital, to make sure they know what you are needing. And then after that, then from there, they will identify what the risk factor they have. They will do the screening for the gestational diabetes. They will do the screening for the preeclampsia if the patient has those symptoms. They will have a number of tests according to what the patient is presenting in the prenatal visit to know what the patient is at risk for. And then if they're healthy, then they're going to continue being seen every 4 weeks, every 2 weeks, until towards the end every week to the OBGYN office to make sure they monitor the weight. And if the baby is growing appropriately, mom is gaining weight appropriately. And then when we get to the pregnancy, then I'm sorry, to the delivery, so then we know if the mom is ready to have this baby. And that's from there, then usually we share that information with our neonatal group to say, okay, this mom is at risk at this level. So if maybe mom is diabetic, then okay, their glucose levels at this. So then we need to worry about during labor and the delivery. We need to anticipate baby might be hypoglycemic, which is the next topic for this education skills. So here in the United States, we do that. In Tanzania, I'm going to let Dr. Banera give a TCL overview for, since he's an OBGYN, he should help us. What are just the overview things that they do for prenatal care for a patient before they come, which help us to identify risk factor for this mom when she comes to deliver. Dr. Banera.
Okay, thank you. For us, we have antenatal clinic, and these clinics are all over the facility, from the lowest facility, the dispensary, health center, district hospital, regional, to the national hospital. And as you said, there are things which are common to every pregnant woman. In the first visit, we call it danger signs. They are taught about danger signs, how to take care of them when they get, and where to go. But those who are identified during the clinic, maybe in the lower facility, they will be referred to the next level. And within the level, maybe if the woman was being seen by a midwifery, and if she has a high risk, she will be referred to the specialist. And for that matter, even the schedule of visit will be different based on the risk factor identified. So what I'm trying to say is everything is in place, but at the end of the day, we get those who have been missed, either by the system or by individual health worker. So at the end, we need to help when they come either late or with the complication. Asante.
Oh, thank you very much. Dr. Msambichaka.
My computer does not like me today, so I apologize, and I'm grateful for my backup here on my phone. I don't really have much to add. I think I kind of caught things that you talked about, Gabon and Dr. Benella right on. I think risk factor screening obviously happens at the intake, but I think I would probably add is if there's no like structure, here there's more of a structure in terms of like you have to ask these questions. So every woman that comes in gets asked the same question so that it's consistent and you're not missing things. I'm assuming that's the same thing. That's how you get your risk assessment. And you have to be, as a labor and delivery nurse, you have to know what is considered a risk factor, because you won't know to call for help if you don't, know what the risk factors are that will impact the baby, to let the baby team aware that, hey, we might be expecting, a fetus in distress. And like I said, the majority of the babies will just be born without much support. It's a few that you have to be able to recognize, and that is by screening for risk factors. What I was saying from a prenatal side, which like Dr. Benella was talking about, like the danger sign. But in addition to that, as a pediatrician, or whenever I get called or I'm informed about the delivery, I want to know all the prenatal screening, what was done, what was not done. Just because the baby is born and my obstetrician colleagues no longer care, I still have to care about, how I care for this baby. Do they screen for HIV or not? It makes a difference to me in terms of how I care for the baby. Do they screen for, syphilis or other infectious diseases? It makes a huge difference how I care for the baby. Is there any blood type incompatibility that I should be aware of? Is mom Rh, negative? It has an impact on how I care for the baby. So there's obviously here we have a set of prenatal screens that are supposed to be done for all moms. That is pretty much standard. It's the standard of care. When they're delivered, when they come to the delivery, the intake person makes sure that they capture all that information, because as a pediatrician, I need to know what was not done and what was not done, so I know how to care for the baby. And like we said, even here in the United States, we have moms that receive zero prenatal care and they just show up. So you have no idea what you're getting. Is it gonna be an IUGR baby? Is it gonna be preterm? Are they gonna be large? No clue. And you just have to be prepared, because every delivery, you have to assume that the baby will struggle. And the majority of the time, they don't, and we're all smiling and we're happy, high-fiving, and we leave the room, and we continue to take care of them. So that was an excellent question. And I think we will learn more from our colleagues when we go to Tanzania, because then we will actually see what they do. And we can maybe learn from them in terms of what things they do well, and see how we can incorporate them in our care here. And maybe they can learn from us and some of the things we will help them make those standard of care as well.
Dr. Benella, did you want to say something?
I'll be asking anybody with a question.
Oh, okay.
From my class.
Oh, okay. No, it has been an excellent first session. Thank you for our facilitators, Dr. Benella and Dr. Msambichaka, for an excellent presentation. Thank you for people who ask those questions, because that's the only way we're going to learn, and we are learning from each other. Whatever we know, we would like to share, and whatever you guys know, we want to learn from you, so we can make the best clinical outcome for these babies, because these babies depends on all of us. So every single one of us should be prepared and ready to take care of this baby. And I'm glad Dr. Msambishaka just said 2 seconds ago that when the baby comes up there, nobody knows that how the baby's going to behave. We can screen, which is great, but baby comes and behave, we have to catch it and help that baby as soon as we can. So if nobody has the burning question, we're going to end. And one more thing, everybody who attended, please send me your email because I need to send you the assessment and the PowerPoint, so at least you have the record. Then I will send you this video after I finish converting. So at least you can have those resources, and we're gonna post it on the website and on our YouTube channel so people can access and be able to get that. But we do need the response from this SurveyMonkey through the email or the WhatsApp. I'm gonna post that link, and then help us improve this training by giving us feedback if there's any way that you think it might be more applicable to yours. And so some of the questions that we did not answer, or some of the topics that you're interested in, please let us know. So next time when the next facilitator comes in, we can just add it to it as long as it's applied to the next session. So we can address your need, because we are all doing this because of our colleagues in Tanzania. So you can better take care of our families over there, and then we can come and learn together and work together. Dr. Msambichaka, do you have anything, final words? And Dr. Banner?
From my end, I just wanted to say that the next session is actually tentatively scheduled for the 26th. This will be hosted by Muhimbili, Dr. Matham Koni, and Dr. Fabian Guido. They will be talking about, once that is confirmed, we will share the link with you. But hopefully, as of right now, tentatively, we will be hosting on the 26th.
Okay, so I think when you're saying the topics, your audio was not clear. Do you want to say again the topic that Dr. Mkonyi and Dr. Ngido are going to cover the next session on May 26th?
Thermoregulation, temperature control, temperature regulation, and glucose regulation. I haven't had my tea yet this morning, so.
I know. Dr. Vanera?
Thank you. I think the next sessions are very, 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 very important. But can we arrange a session where we will have some midwifery taking us through the fetal monitoring, so that you anticipate to resuscitate a baby after having the fetal monitoring pattern? I'm not going to be part of that thing, but I wish if there is somebody there. We know we are monitoring different. We are monitoring manual, and you are doing it electronically. So we can have that session so that we anticipate who is to resuscitate by using monitoring here. And if anybody there, it will be important to know. We know here in our hospital we have the CTG. See, we have CTG, but we are just using partly, as we are just taking the fetal heart rate. But I think it can do more for the monitoring part. So if we can arrange maybe the other session before we go to more sessions, advanced session, it will be important for us for the team.
So I missed the first part. So you want to say?
Yes, intrapartum fetal monitoring.
So that probably will be an added session, because the ones that Dr. Msambichaka has already scheduled their specific content. But I do agree with you, yeah, monitoring a labor patient and a baby, you're gonna start with a fetal surveillance of the baby before the baby comes out. So hopefully baby can give us clue for how we're gonna react after the delivery. So I think that might be just a discussion on the side, but yes, we can add another session and we figure out which days, because that's gonna require the OB people, labor and delivery nurses, and of course the midwife definitely to be in there to be able to address that area. But yeah, that's an excellent point. Yes.
Otherwise, asante sana.
No, thank you very much for bringing everybody on your team there. And if you can, please, after the meeting, I just need their names and their email so I can send them the information, make sure who is responding, who is attending. So we want to make sure so when we come over there, we know who has the knowledge at least from this virtual learning, and then we can do the clinical skills, because it's easier then we know where they are, and then so we can work with them from there. So that was, thank you very much for that effort, because it's great to see a lot of people that are there. So thank you. Okay, if no one else has, for people who have been in on a Zoom, if you can just send me just type in on your chat your email also, just to make sure, so I can get your audio when it's done, the PowerPoints and the assessment from the SurveyMonkey. And if not, so I think it was a very good first session, and I thank you for coming early. For people from United States, thank you for waking up that early, but and thank you for people in Tanzania for coming and stopping everything you're doing to come and learn and improve your knowledge, so we can take care of these babies. And we welcome all the questions, feedback, as I said, and thank you, Dr. Banela, for all the work we did. I know there was Dr. Kilo Woko from Buguruni. I heard you came in, so thank you very much. We appreciate that. And Dr. Komakoma from Buguruni, thank you very much. I know Dr. Mushiro was there for for Muhimbili. Again, thank you also for coming. But I need those contact information so I can send this the presentation so we can keep going. And if for the leaders of those 3 hospitals, if you know your staff that they needed to get this education, please share with them as soon as you can. So when you're coming to do in 2 weeks, as Dr. Msambichaka said, we want those people to have that foundation from this one. So when we are building on, we're talking about the hypoglycemic and stuff, or thermoregulation, at least we know the physiology behind of this baby. So we can build on it instead as people be missing some of the points because they don't have that knowledge. So again, without keep talking, and I say thank you very much for your time, and until next time. Bye, guys.
Great job, great job.
Thank you, guys. If everybody can wave so we get a screenshot. For people from Mananyamara, if you can wave. We want to get the screenshot. Yes, thank you, thank you. Okay, bye, guys.